I am Magdi Yaqub from Osman Health Center in Imperial College London.
Would you like to? Maybe we'll get going with the first talk, which is Global Epidemiology and Rheumatic Heart Disease from Dr. Kritit from Aswan. So we're really looking forward to hearing your talk.
So, good afternoon, everyone. I hope you enjoyed lunch and the previous session. It was wonderful. So now this will be a session on rheumatic heart disease, which is still a huge problem in many regions and many countries, including Egypt. So I'm Susie Kotit, I'm from Oswan Heart Center, and today we will be discussing some of the global burden of disease, as well as epidemiological trends and the challenges related to rheumatic heart disease. So rheumatic heart disease affects millions of people worldwide and accounts for a significant number of mortality, leading to loss of life and loss of quality of life. And this burden is mainly in the regions that are facing low and middle income issues. So you can see on this graph, there should be a map on it. Now it is. So we can see the disparities on this map, and we can see the huge differences between low and middle income countries compared to the high income countries based on the prevalence of the disease. And 80% of the cases of rheumatic heart disease are actually based in the low and middle income countries. So there is a huge variety in regional prevalence of rheumatic heart disease, and the highest prevalences can be found in sub-Saharan Africa, as well as South and Southeast Asia and the Pacific Islands. And actually the cases in sub-Saharan Africa, they account for 23% of all worldwide rheumatic heart disease cases, and account for up to 34% of the cardiovascular admissions in the region. Alarmingly, there is a lot of subclinical and undiagnosed rheumatic heart disease in sub-Saharan Africa. And here we can see the distribution of prevalence and death at global and regional level. And we can see that the age standardized prevalence is the highest in sub-Saharan region, and the age standardized death or mortality is the highest in South Asia. And those are some of the discrepancies. So in high-income countries, rheumatic heart disease has a prevalence as low as 1 per 1,000 children, or up to 0.5 per 1,000 adults. And there has been a significant decrease in the prevalence and the incidence of rheumatic heart disease in high-income countries. And this is mainly due to the improved living conditions, better treatment, better access to healthcare, and the use of penicillin. Currently, rheumatic heart disease persists in the marginalized population, which is the poor or indigenous communities in high-income regions. However, there has been a recent trend showing a rise in rheumatic heart disease cases in high-income countries. And we can see here on the different graphs and different regions, including some important European countries, as well as the United States, showing that there has been an increase in rheumatic heart disease incidence. And this has been, it has been said that this is due to migration from regions with higher rheumatic heart disease prevalence. However, an analysis of rheumatic heart disease burden over 10 years in the US has shown that the most cases found were endemic rather than from a foreign exchange or export. So currently, we can see here that in the past decades, there has been an increase in the incidence of rheumatic heart disease cases based on the social, in social and geographical regions. And high-income North America, high up there, shows a high increase as well. Pointer is not working, so I'll go back. Apologies for that. Okay, yeah. So we can see it's, yeah. Yeah, now it's working. So we can see that in high-income North America, there has been an increase over the past decades, and that this increase is consistent in South Asia, as well as Eastern Sub-Saharan Africa and Western Sub-Saharan Africa. So moving on, we can see here in the different regions that there has been an increase in age standardized prevalences among low-income countries, but as well as among high-income countries, which is quite worrying. So we can see here the percentage change in age standardized rates between 2000 and 2019, and we can see that the highest rates have been localized around the low and middle income countries, and also the estimated annual percentage change is the highest among this region. So when looking at the age distribution, we can see that the prevalence of rheumatic heart disease is the highest among the youngest. So in this age group 20 to 24 up to 40, 45, we see that this is the highest prevalence, and we can also see that among all age groups that females have a higher predominance. So there is huge gender disparities, and there is a higher risk for rheumatic heart disease among females, and this disparity is even more evident in low and middle income countries compared to high income countries. And hospitalizations are also more frequent among females than males, up to 3 times. And rheumatic heart disease is a leading cause of maternal cardiac complications in pregnancy worldwide, and it contributes up to 3% of cardiac disorders in pregnancy and account for up to 41% of indirect obstetric death in low-resource regions or settings. So maternal adverse events are expected in almost half of the females with rheumatic heart disease who are getting pregnant. So when looking at mortality, there's also a discrepancy between males and females, and we see that mortality is more frequent in females, and even in high-income countries, we see that there has been a decrease or a decline in mortality due to rheumatic heart disease. However, females still do have worse outcomes and more mortality. And when looking at Germany, Germany is one of the countries that has shown actually an increase in rheumatic heart disease-related mortality. We also see that females still do have higher rates of mortality and worse outcomes. So when looking at this graph, we can see that rheumatic heart disease actually affects the young, usually the young, more in females and mainly in the low and middle income countries. And regarding the age standardized DALYs, we can see that South Asia is really highly representative. And when having a look at the distribution of these DALYs, we can see that it starts quite early on. So children around 10, 14 are already here represented on this graph. Females more highly representative, and usually more in the low and middle income countries. So when looking at the composition of the disability-adjusted life years in 2021, we also see that for disability and premature mortality, females are more represented, have a higher representation throughout all the age groups. So throughout all the age groups, starting from a young age up to 95 years of age, females do have higher DALYs. And it's also important to remember that rheumatic heart disease accounts for a high proportion of years lost due to disability in heart failure. And this trend has been increasing, and it's expected, and in the coming decade, it will have even a higher increase in this trend. So the burden mostly in low and middle income countries, among children, adolescents, and women in childbearing age. What does the future hold? How will it look like, and what can we expect? And looking at a forecasting model based on GBD data from 2019, it's predicted that the age standardized prevalence for rheumatic heart disease will increase globally, especially in the low and middle income countries. So there is a higher trend for it. So when looking at the estimated annual percentage change, we can see that there is a worryingly increase in the annual percentage change throughout all the regions, and as well as the high SD eye regions, which is also alarming. And if we go over the 21 GBD regions, we see that there is a most prominent increase around all regions for the expectations up to 2030. So when looking at different genders, again, females are more represented in the expected prevalences in the next decade. So there has been an increase, and there is an expected increase in female burden of rheumatic heart disease compared to males, and this disparity is actually expected to grow even bigger. So it's going to be even worse. So when looking at the changing trends of rheumatic heart disease-related disease burden, we can see that there has been an increase, and there is an expected a higher increase in age-standardized prevalence rates. And we can see that this is globally and affecting mostly the young population, which is around 10, 14, up to 35 and 40 years old. So this is a significant, significant data. And looking at the the regions at the highest risk or with the highest burden, we can see that the low and middle income countries are the most represented. So I want you to take a second and forget everything I've just told you, because everything is based on an underestimate. We have been underestimating the prevalence, the burden, mortality, incidence of rheumatic heart disease. And why is that? It's because we actually have limited data, and we use different methodologies. We use different diagnostic criteria. We have poor quality of data from low and middle income countries, and there are a lot of diagnostic criteria around. There is misclassification of causes of death, and we are relying on hospital-based records only. There's a lack of echo screening, which is very important to detect subclinical rheumatic heart disease, and there are methodological changes in the most studies being presented. Also, when we focus on school-based surveys, we are underrepresenting the true burden of disease, because poor, sick children with rheumatic heart disease are probably going to skip school, and they will not be attending. Also, the peak of rheumatic heart disease incidence is after school age. So if we're focusing on children from 5 to 16, then we are definitely missing the peak incidence of rheumatic heart disease, which will lead to an underestimate. There is also inadequate access to healthcare in the regions that are mainly affected by rheumatic heart disease. There are a lot of competing health priorities overshadowing rheumatic heart disease, and there are weak health systems with also underreporting of the condition. And definitely rheumatic heart disease remains neglected in the global health discussions. So what do we recommend? We would like to see the development of databases and national registries. We would like to see established standardized procedures for collecting epidemiological data, and we would like to see that this data can cross-communicate and data exchange among the different institutions. We need also simplified echocardiographic criteria, because if you have ever done a screening or if you have had to analyze a patient, too many variables will actually make it more difficult for you to diagnose. We need to make rheumatic fever and rheumatic heart disease notifiable diseases so that we can actually know what the burden is. And we need to integrate rheumatic heart disease programs into the primary healthcare systems. And of course, I think we made a very good start here, this meeting, and I've met a lot of people who are very enthusiastic. We need more partnership between low and middle income countries and high income countries with exchange of expertise and interest, and maybe we can make a difference. Thank you so much.
Thanks very much. I think we'll save the questions for the end and have a bit of a panel discussion. So it's my great pleasure to invite a colleague and friend, Elena Akawa, up to discuss from a molecular level, from an epidemiological talk we've just had, to a molecular level of rheumatic heart disease. Looking forward to this discussion.
All right. Good afternoon, everybody. Okay, thank you. Good afternoon, everybody. I am extremely happy to be here. I think this meeting is amazing, the venue is outstanding, and the place is better than it could be. Cannot be better. My chair today is Sir Magdi Yaqub. I mean, what you wish for in this life. So today I'm going to talk about rheumatic heart disease, from molecular mechanisms to the community. But before I start, I want to show this picture. I don't know if you recognize some of those people, but it's in the middle is Sir Magdi Yaqub, and you can see Donald Ross. We talk about him today a lot. And somebody, I think Dr. Joseph Bavaria, just said in a previous session that Ross is great, indeed. And you also see myself here 25 years ago. And what happened now, right? It's big difference. Now we're here. The previous picture was the picture 25 years ago, in 2001, a little bit less than 25 years ago, where when Sir Magdi Yaqub organized the first meeting of the Society of Heart Valve Disease. So, and this is here 24 years after that. And now we're combining Heart Valve Society and International Conference for Tissue Engineering. I think it's the best of the both worlds. And those are actually my trainees, current and former, and my mentor for almost half of the century, Sir Magdi Yaqub. Thank you. All right, so now let's talk about rheumatic heart valve disease. And as our excellent previous speaker said, that this is a major health burden around the world, and you can see it on this map. But you know, problem is that there are many problems, and she listed all of them, or at least most of them. But one of them, that this disease is understudied, because there are not so many research is done in different countries, low-income and high-income countries on this disease. Therefore, global scientific and government partnership are essential to support research on rheumatic heart disease. So we all know that it starts with untreated Staphylococcus pyogenes throat infection, which then became acute rheumatic fever, and then eventually chronic disease affecting aortic and mitral valve, mostly mitral valve. So this is how rheumatic mitral valve looks like. The leaflets become thicker. The leaflets histologically have lots of fibrosis, shown here by picker series red. You could see inflammation and calcification. And we recently also demonstrated that there are network of micro vessels in these valves, which could be also lymphatic vessels. However, again, the mechanisms are largely unknown. Therefore, several years ago, not several, actually a couple of years ago, Leduc Foundation have a call for acute rheumatic fever biomarker project. And we were very privileged because we were selected to be one of the two groups who received the funding for this project. So the idea is to understand or discover biomarker for rheumatic valve disease and also look at the mechanisms of this disease. So our first paper was just published in Circulation, and this paper demonstrates discovery of protein alpha, or PTMA. As previous speaker mentioned very clearly, and I won't go through this table because of the time constraint, but it's clearly showed that this disease is prevalent in women. As you can see here, 87% of women have this disease, and only 15% of men, at least in our cohort, this disease. But I think it's a worldwide trade. trend. So this is our workflow. This is unbiased proteomic and network analysis, which helped us to identify PTMA as a novel protein associated with rheumatic valve disease. We also showed association of PTMA with estrogen signaling. And we were extremely happy about it because PTMA has already demonstrated increased activity of estrogen receptor or ER alpha in this couple of papers published previously. So we started looking at PTMA expression in the rheumatic valves, both aortic and mitral valves, and we saw high expression of PTMA in CD45 positive cells, but not in fibroblasts. We also demonstrated positive correlation of PTMA with valve thickness. This graph shows that circulating T cells from patients with rheumatic valve disease show increased expression of ER alpha, and their number correlates positively with PTMA expression. CD8 T cells in blood and valve tissue also correlate positively with PTMA expression in those patients. And importantly, ELISA demonstrated that levels of PTMA are very high in patients with rheumatic disease, suggesting that it could be potential biomarker. So this is a very complicated slide, but basically it demonstrates that PTMA causes increase of cytosolic proteins, so-called granzyme B and perforin 1 in CD8 positive cells. And particularly, it was increased in cells which were treated with both PTMA and estradiol. Recombinant PTMA increased ER alpha expression in CD8 positive T cells, which were positive for both granzyme B and perforin 1, and also demonstrate colocalization of CD8, granzyme, perforin, and PTMA in the cells in valve tissue. So the next we ask ourselves the question, how PTMA can contribute to CD8 positive T cell interaction with valvular tissue? And here we found that recombinant PTMA increases VLA2 or type 1 collagen binding receptor in CD8 T cells expressing both cytolytic enzymes. So we then went back to our proteomics data and look at the collagen in those cells, in that data, and we showed high abundance collagen type 1 in both mitral and aortic rheumatic valves. So now let's just switch the gears and think how this data, which I just showed you, could contribute to autoimmune mechanisms of rheumatic valve disease. So what is our autoimmune disease? In general, it's when your own cells could affect your own tissue. So we thought that human valvular collagen type 1 is a cross-reactive epitope in this tissue. And indeed, we found that several peptides, in human tissue overlap with Streptococcus pyogenes surface-like protein. And we also used in silico methods to demonstrate CD8 T cell epitope. And we predicted it epitope using this methodology. Here we showed that two epitopes, number 1 and number 2, I think one is green, one is purple on this slide, have these cross-reactive epitopes in both, with both human and Streptococcus pyogenes. And then we had to do immunostaining. For that, we actually used custom antibodies, which show CD8 co-expression with epitope 2 in valve tissues. And finally, we showed that PTMA increases expression of MHC1 complex in valvular interstitial cells, suggesting that valvular interstitial cells could be efficient antigen-presenting cells. In conclusion, PTMA is a novel contributor to autoimmunity and potential regulator of sex predisposition in patients with rheumatic valve disease. With that, I would like to acknowledge my postdocs in Aikava lab, particularly Olivia Passes, who led this study, and Pravash Jha, who showed us, who demonstrated the co-expression of two epitopes in human tissue and bacteria. Thank you very much for your attention.
Thank you, Dr. Elena. The next talk was supposed to be early detection of rheumatic valve disease by Anna Olga Mukombi, who is not able to attend. So we're going to move straight to the ARGI registry, rationale and preliminary results by Suzy Kotit.
So it's me again. So I just showed you that rheumatic heart disease still holds a huge burden of disease around the world, and I've showed you the predictions of what's going to happen in the next decades, and I gave you a load of recommendations, but what have we done about it? So this is what we've done about it at Aswan. We have a rheumatic heart disease program in which we recruit patients with rheumatic heart disease. We have developed a database in which we incorporate all the clinical and echocardiographic data of the patients, and we are taking samples for the very valuable analysis, like discussed by Dr. Aikawa. And we are providing follow-up and interventions for this population. And this registry has started a while ago, like in 2009, and nowadays it holds around 3,000 patients, consecutive patients enrolled at Aswan. So how does that look like? So our patients present at the clinic with rheumatic heart disease. If they have mild disease, they go for medical treatment. If they have severe disease, they go for medical treatment versus intervention or both. And then the intervention can be percutaneous or surgical. And then we have regular follow-ups every 6 months. We did preliminary analysis of the data, 2,595 patients we analyzed, and we had a female predominance. 68% of the patient population was female, and the average age was 40. But I'd like to remind you that we are a referral center, so most of these patients were already diagnosed years before presentation at our center. So this does not mean that individuals presenting to us that this was the first presentation at all. And most of the patients had significant symptoms and significant severe symptoms. So they also had a history of morbidities, specifically atrial fibrillation, pulmonary artery hypertension, and strokes and TIAs, and of course, prosthetic valve thrombosis. So they also had a load of previous interventions, up to 4 interventions before presenting at our center, which if you look at the average ages, you can see that this is quite young for having 1, 2, or 3 interventions already in the past. The type of interventions were mainly balloon mitral valvoplasty, followed by valve replacement. And the affected valves were mainly triple valve disease. So we saw a lot of triple valve disease, followed by mitral valve disease plus tricuspid valve disease. Isolated aortic valve disease was not very common. More common was the isolated mitral valve disease. So the most common pathology was mitral stenosis, followed by mitral regurgitation, and then followed with all the other pathologies. So we followed these patients up to almost 14 years after the first presentation, and we saw that actually the symptoms with the medical care, they had improved. Still, a lot of patients did have symptoms, but the severity of these symptoms had improved. During the follow-up time, a lot of patients had new morbidities. They had developed new morbidities, which included atrial fibrillation, pulmonary artery hypertension, unfortunately strokes, and there were 19 prosthetic valve thromboses for which the valve was replaced. So what kind of interventions did we do during follow-up? We had a huge amount of mitral valve replacements, but we also have a good amount of balloon mitral valvoplasties and mitral valve repair and aortic valve repair. And another good thing is that we are using a lot of bioprothesis in the mitral and as well as in the aortic position. And then we wanted to see the impact of having an intervention versus not having an intervention in this group on the outcomes of the disease. So we had the intervention group, which accounted for 54% of the patients, whether they had surgical intervention or percutaneous intervention, and that was group number 1, the intervention group, and then group number 2 were the patients that had no intervention whatsoever. And then we looked at the outcomes, and the outcomes were defined as survival or combined endpoint of cardiovascular events like atrial arrhythmias, thromboembolic events, or cerebrovascular accidents. And we noted 385 adverse events during follow-up in this patient population. And here we can see the differences between the group that was operated on, which is the green line, and not operated on, the red line. And we can see that definitely green does better. So intervention had a good impact on the cardiovascular events. Unfortunately, again, we saw 13% of our patients dying, and the early 30-day mortality was around 4%. And again, when looking at the outcomes for mortality, we see that the survival probability was the highest in the patient group that had an intervention. So intervention was leading to less cardiovascular events and better survival of these patients, as we can see in this image. Then we thought about looking at the hazard ratios of patients with events, history of events, and patients with no history of events. And we can see here that actually having history of an event, it increases your risk of having a new event. And that having no history of event actually had a better risk score. And we can also see that having a procedure versus not having a procedure is also better for the outcome for the risk of events. So in conclusion, we saw that previous cardiovascular events are a risk factor for new events, and the risk for new events are also decreased by interventions. And this also has better impact on patients who actually never had an event before, so they also see better cardiovascular outcomes. Unfortunately, rheumatic heart disease has shown to be progressive, and it shows a continuous deterioration in cardiovascular outcome, even in patients who were under medical treatment, regardless of having an intervention or not. However, the intervention slows down the deterioration of the disease and lowers the cardiovascular events and the mortality. Young patients in our cohort still under medical treatment, they have high morbidity and high mortality. So future directions, we really would like to see the standardized procedures for accurate epidemiological data and cross-communication between data, but we are really aiming at better patient care, enhancing penicillin prophylaxis, enhancing diagnosis of rheumatic heart disease, improving access to cardiac and reproductive health services, establish centers with the so essential cardiac service and surgery, providing follow-up and monitoring of outcomes over time, and improve access to surgery. So in the future, we should focus on prevention versus advocacy, implementation, and research. And at our center, we're very interested in research further on our samples, and we will focus on genetic susceptibility to understand why some populations do have higher prevalences and higher burden of disease. versus the diversity of the strains as well as the virulence factors of those strains. And we would like to aim for better diagnostic tools, whether that's in the form of biomarkers for early detection or prediction of disease outcome, but also for AI learning models for risk stratification and improved echocardiographic diagnostic tools, maybe in combination with AI. And eventually, we are aiming for development of a Group A Streptococcus vaccine to actually eradicate rheumatic heart disease altogether. Thank you so much for your time.
Thank you very much. Now it's time for discussion and a lot of, hopefully, contribution from the floor. First one. Thank you. Can you identify yourself, please? We can't hear you.
I think we can check his microphone.
فيش نو. سامح الأمين, consultant cardiac surgery, National Heart Institute. Dr. Suzy, you have a very good illustration for increasing prevalence of rheumatic heart disease globally in low income countries and high income countries. How can you explain the etiology for this? The cause, yeah.
Why is it the increase in prevalence of rheumatic heart disease in high-income countries as well?
The question is why rheumatic heart disease continues in high-income countries. Is that right?
Yes.
I think for two reasons. You can answer that question, but anyway. One is that there are endemic group, low-income people, neglected in high-income countries, so it is related to socioeconomic conditions, one. And the second is that there are definitely rheumatogenic streptococcus, which increase the likelihood of producing rheumatic heart disease, and it can be affect like measles or any other infectious disease, rheumatogenic bacteria. These are the two things, but the third, obviously, again, is, sorry, I didn't mention the third one, is genetic. There is definitely a strong evidence that rheumatic heart disease can run in families. So if you find one person affected in the family, there is a higher incidence of rheumatic heart disease in the same family. Yes. Now, identifying all these things could be useful in preventing rheumatic heart disease in not only in endemic area and low-income, middle and low-income countries, but in higher income countries. Yes. Have I addressed your question?
Yes, thank you very much. And this is true. It's running in families more common, as we see here. Yeah. Can I have another question? The second last talk, you said that rheumatic heart disease is progressive. Do we have any plan to stop the progression of rheumatic disease in rheumatic heart patients?
So the question again?
Do we have a way of stopping the progression of rheumatic heart disease?
What an excellent question. First, we have the secondary prevention and the primary prevention. The primary prevention has not been very effective worldwide, and the secondary prevention, even people who are having penicillin or prophylactic measures, secondary prevention, who has developed disease, they continue to have attrition like what Dr. Cotit has shown in the RG trial, but also in another multi-center trial. That is not, we don't know why there is a continued activity in the valve which affects survival of patients even after they have had appropriate treatment, either medical or surgical, and prophylaxis. And that should be the focus of further investigations. So you're absolutely right.
Thank you very much.
Thank you.
Would you allow me to add another point, Prof? I think one of the most effective ways to help with eradication of rheumatic heart disease is raising the socioeconomic profile of the population. And this could also help very much, so rather, not just primary and secondary prevention.
And if I may add one comment, I think that raising the socioeconomic status of people is, we've talked about it and it's well known, but like in high-income countries, why is it still occurring? It's tough to do. But I wonder one thing is the success of eradicating rheumatic heart disease in this country leads to complacency, because we know that one of the factors that leads to people getting care is self-seeking health behavior. If you have a sore throat, you go to the doctor. Penicillin is cheap, access is readily available, but why are these people not going to the doctor when they have sore throat? I wonder if because we had such success in eradicating rheumatic heart disease that it's become something on the back burner. No one thinks about it anymore. Because we know in low and middle income countries, when people are sick, they just don't go to the doctor or they don't have access to health care. Whereas on the contrary, in high income countries, you just go, you get penicillin, you treat it and you go home. It should be fairly simple, but I wonder if that's part of the reason we've seen a resurgence, because as we've seen in some countries, not to name any countries, the success of vaccination has become contentious now, that people are beginning to question why certain diseases are coming back when, because vaccination was so successful that people just don't remember how bad measles was, how bad, other diseases were. So now they start to question whether we need to keep vaccinating people.
Yeah, I would like to add something else. Because of the economic struggles nowadays and the challenges and the lack of access to healthcare, even in the high-income countries, we are expecting that trend to rise even more. So enhancing the economic status of the patients is will definitely make a difference, but also raising awareness, because we have a lot of subclinical disease and patients do not have an idea that they are struggling with rheumatic heart disease. And another thing is that even after they are diagnosed, penicillin prophylaxis and negligence, because there is lack of awareness, is also a definite factor for the worsening outcomes.
Yes, sir. Okay. Yes, sir.
Thank you. Juan Amaya from Colombia originally, and now somewhere in the southeastern United States. It's a fascinating presentations, Dr. Cotia. It was wonderful to see. One of the things that I found very surprising is that Colombia was actually in the low range of rheumatic heart disease, which is what we saw over the last 20 years or so. And it's not necessarily because the socioeconomic level was raised, it's because the access to healthcare was prioritized and made easier over the last 20 to 25 years. Something that's happening in the opposite direction in the United States right now. I saw that 33% of the patients in the surgical arm underwent a Ross procedure. And Chris Moraes and I were talking about this and wondering, what about the Ross in rheumatic heart disease?
May I answer that question, because I think this is an important question. where there is some confusion, because there has been some reports, especially from Saudi Arabia, saying that because the Ross operation uses a living valve, that living valve in their environment could be the subject of further rheumatic problems. This is hotly disputed. I myself would have never seen it, and we have a relatively large series at Harefield and the National Heart, and this. Usually the affection is due to either infection or something else, but not recurrence of rheumatic heart disease, and this needs to be investigated further. So the Ross operation is a very effective method in developing countries, and certainly in Aswan, people with rheumatic heart disease, they are young, and they would benefit from the Ross operation. Do you want to comment on that, Ismail, for example? Or you, from South America.
Yeah,
What is the experience?
We're going to present our data on the Ross, on rheumatics at the last paper of this session. So 25 years of follow-up and good results, and we're going to compare with the ASWAN, the recently published ASWAN results with, I think it was 28 patients or 30 patients. We're going to present a little later. But the results are good.
He's going to present.
Could I ask about the Ross and rheumatic heart disease? Does it matter the age?
But can you give us an inkling what you're going to say? It bears repetition.
No, what we saw is that the autograft durability was similar between rheumatic patients and bicuspid aortic valve patients. Out of 147 patients followed for 25 years, we just could see 3 patients that were reoperated due to rheumatic involvement of the autograft.
Recurrence of rheumatic.
Yeah, so, but just 3 patients out of 147. So very low, and the durability was the same.
Very unusual. Is that what you're saying? Okay.
Yeah, but that's the same results I think the Oswan group just presented up to 10 years. So,
can I ask a question though about that? You know, what is the age? What's the demographics of the patients? Because if you've seen a 25 or 30-year-old or 40-year-old with end-stage rheumatic heart disease, hopefully by then the rheumatic fever curve is down. So what about a younger patient, a 10-year-old or an 11-year-old who's going to go back into the same at-risk environment with repeated infections? How do you prevent that?
that's a very good question. All the recurrences that we had were younger patients younger than 30 years of age. Curiously, we didn't see any relation between good prophylaxis afterwards, after the operation, doing penicillin or not. We couldn't find no correlation. But younger patients, of course, they are more prone to recurrence. That's probably true. But when you have burnout disease already, on the chronic phase, I think recurrence is not common.
Yes, sir. Dr. Semen.
Jordan Miller. So it's very interesting with the biological aspects of this, and also some parallels with cancers. If you look at PTMA, for example, in cancer, it's associated with chromatin decondensation and genomic instability and long-term genomic instability. So do you know if, when you're looking at the persistence of progression of disease, is that associated with genomic instability, double-stranded DNA breaks, things like that in the mitral valve? And subsequently, is that an opportunity for biomarkers as you're looking for increases in circulating genomic fragments that have double-stranded breaks that are not consistent with other sites that are unaffected for potential intervention?
Very interesting. The markers of the disease that you've told us in your trial, that could be effective in any type of degeneration and possibly rheumatic heart disease, would you say? And some of the markers Dr. Aikawa has mentioned as well. I don't know, maybe the new drugs, we haven't got a vaccine, it's a disaster, but what's your take on that?
It's a great question. I think, honestly,
Microphone is not working, I think. Okay.
I guess when I look at the biology of rheumatic heart valve disease, I think we're still in the stages of infancy there. And with calcific aortic valve disease, I feel like we've known a lot, but it's been really difficult to identify therapeutics that are going to attack that, viably and therapeutically. And so, with regards to overlap, I think, context matters, right? And we had published a couple of years ago some in myxomatous mitral valve disease that there's upregulation of, quote, osteogenic signaling, but it's actually serving to drive proliferation largely in a younger population. And so I do think there's opportunity for maybe using similar therapeutics to target similar pathways that are yielding different phenotypic outcomes, almost based, in some ways, from 50,000 feet, based on age, right? So a younger patient might have a more proliferative phenotype, and an older patient might have a more calcific phenotype. But that's just a lot of conjecture right now. That'd be my guess, yeah.
Great.
Excellent session. My name is Jessica Forcillo. I'm a cardiac surgeon from Montreal. My question is for Dr. Koutit and the panel. So in terms of your recommendation, and you touched about awareness as well, but are there any global standardized initiative about bringing awareness at the population level? And also, do you have like screening campaign in the community to do so? And if those campaigns, would this health system be able to afford all the under-detected pathology that you're going to find after?
So we don't have a screening program. We don't have a national screening program, and rheumatic heart disease is mainly undiagnosed until it actually is symptomatic and it's too late. So we don't have any of those initiatives. So we are actually receiving the patients after they have been diagnosed with rheumatic heart disease. There are no funds, and currently we are working at the Aswan Heart Center for the prevention program. So we have developed leaflets for patients. We are trying to teach at least our patients about the compliance for the warfarin, compliance to penicillin, and so forth, but there is no national initiative. So we are actually taking the initiative at Aswan Heart Center to provide patients and everyone interested in rheumatic heart disease and actually rheumatic fever as well to go and look it up online, because we have booklets, we have pamphlets and everything else. But there is no huge initiative for it. Yeah, thank you.
Yeah, so I'll say that, the reason it's an endemic and chronic disease is the disease of the poor, right? No matter how we dice this up, there's not money to go after this, it'll keep, living. And it's no surprise that it's more prevalent in sub-Saharan Africa and in Asia, other places where people are poor. So until there's a global initiative, and if you look at the timeline of announcements, from the Geneva Accord, the Drakenberg Declaration, that's the Cairo Accord. Almost every 2 or 3 years, there's a general sense that, let's talk about rheumatic disease, let's raise awareness, then it just dies down. Mm-hmm. It boils down to money, and I think that, attacking at the source, which is awareness that you have rheumatic fever, is probably the biggest bank that we can make to change the issue. Because once you get to rheumatic heart disease where you have chronic valve changes, the horse is already out of the barn. Now you're dealing with, treatment. But the focus should be on prevention, which is raising awareness. So just like maybe HIV, the biggest world campaign for HIV, if you could do the same for rheumatic heart disease, then maybe we'll make a difference. But the question is who has, the wherewithal and the money to go after this. Rich countries are not interested in it because it doesn't affect them. Poor countries don't have the money, so they won't do it. And they can do it, And even when they're given the money, they have other priorities to use the money for that changes the balance and where they invest their time. So.
One quick comment. Actually, all the service provided by our hospital, Professor Magdi Yaqub's Aswan Heart Center, is for free. It's charity. So everyone is being treated, followed up, and being taken care of in all matters, all free of charge. So I think that's a huge difference, and it makes a huge impact in the load of the disease and the burden of the disease.
Maybe I can also just answer the question from a South African perspective with regards to screening. So predominantly, there's no national screening program, but all the screening has happened in the realms of research. So like the Remedy study that was done by Bongani Miosi and Liesl Zilke, and that really, tracking rheumatic heart disease through large research projects as opposed to national initiatives. I'm going to follow that up with a question, an open-ended question to, I suppose, I'll start with you, Dr. Kudit, but it's to everyone. And that is, we've noticed that the age of presenting patients for cardiac surgery has increased in the last 20 to 30 years, where patients that used to present for heart valve replacements was in their 20s to 30 years of age, it's now in our 40s to 50s. And the predominant patients do not report, and they cannot report an episode of rheumatic fever. So we're not sure if there's a more indolent form that is happening right now. Is that a socioeconomic issue? Is that a multiple hit issue? Is that a different disease process? Why are the patients presenting 20 years older than they used to?
The first thing about the recurrences and the history of rheumatic fever, our patients do not have a history of any of those. So they don't recall any rheumatic fever events, they don't recall the recurrences, and they're actually diagnosed based on cardiac symptoms. So that's one thing. Usually in Egypt, we go first because we have mainly mitral valve disease, mitral valve stenosis, we go for the balloon mitral valvoplasty intervention first. So that's the first step. So if you go through with that, you'll probably push a bit the intervention age further. And then you will go on for the surgeries. That's one of the things. I don't have an answer for why your first intervention would be at a later age, except maybe better treatment or better economic status of the patients in which they are more aware of the available penicillin prophylaxis or treatment options, or maybe even a better health condition.
Yeah. Yes, Philippe Pibarou from Quebec, Canada. Great session with all the masters. So I think it's good to discuss, Ross operation and surgical correction of rheumatic heart disease, but ideally we should avoid to get there. And again, I will insist and get back to this importance of screening. We need to implement screening not only for research, but for clinical purposes. And I think we cannot bring the people to the hospital for screening. We have to bring the screening campaigns to the people, to the school. Of course, easy to say, difficult to do. It has some cost. But, and there are some groups who, including the group of Elena Aikawa, who try to develop blood biomarkers that ideally are specific to rheumatic heart disease. This is a challenge. And that could be used, and eventually in the future we could develop some low-cost tests to do a point of care with just a drop of blood and detect rheumatic heart disease, as we did for COVID. So this is feasible. In the meantime, what do you think is the most efficient way to screen for rheumatic heart disease? Is it e-stethoscope with AI-based application to detect heart murmurs? So obviously not. Is it POCUS and ECHO? Is artificial intelligence potentially useful in order to be able to do large-scale screening campaign? What is your approach?
So I have a very sad experience with screening school children. So we screened 3,000 school children in Aswan, and we detected some rheumatic heart disease. We called them for follow-ups at our center. They never came because they were subclinical. So the parents and the children themselves do not want to believe that they have something in their heart. So that was not so good for our reputation. Anyways, afterwards, so no one appeared. So that's for the screenings. And then again, we're screening children from 5 to 15 years of age. So you're also missing the peak of the incidence. And then you have to really tell people that they are actually, they have subclinical disease and they need to go for treatments, which is not easy. So that's for the screening. Regarding the influence of AI, I think we definitely need to simplify the echocardiographic diagnosis with the help of AI, because it's very difficult to screen, to have huge screening programs with very specialized and very difficult diagnostic criteria in which you have to make a lot of assumptions and a lot of calculations. So we need really a more simplified and easier way to diagnose with echocardiograms. We don't use the auscultation anymore because that under-detects rheumatic heart disease. So I think AI is definitely up for next for the evolution of the echo criteria. Thank you.
Yeah, and I have the privilege.
So the AI could be very useful, but what would you feed into AI? Electrocardiogram, certain markers we're talking about? It has been useful for the diagnosis of hypertrophic cardiomyopathy, for example, which is amazing from just an ECG, or age, or other things. But we need to feed certain parameters. What parameters do you think we should be feeding?
I think there's a lot of interest in AI diagnostic criteria for rheumatic heart disease in the US, and there's a team working on the mitral valve regurgitation, but I think that we should focus more on the structural changes of the rheumatic valve so that we can actually have better idea of the outcomes of this rheumatic valve, of whether it is actually rheumatic or not. So structural characteristics of the valve would be essential.
So deep learning on echo images, I agree.
Yes.
And I am the editor-in-chief of the Journal of Heart Valve Society, and I have the privilege to announce that we're going to have a focus issue on rheumatic heart valve disease. So please submit your papers. I will certainly invite you to write review articles. Thank you.
Thank you.
So just a very quick comment on the how can we diagnose with AI? You cannot have cardiologists that would screen millions of children, because we don't have enough, and otherwise you don't want to assign these cardiologists into other things. You have to do like very simple, like the focus echo, where general practitioners would have very generic screening, and then the AI would reconstruct this and get data. This would eventually be applicable. It is not yet, but I think this is something. Otherwise would be like 3D probe, take whole volume, and then the AI would do the thing. But again, this needs hardware, which is expensive. So you have to make the screening easy for people, because you cannot get specialists do things, otherwise they have other things. So just
the aim would be one image screening. So based on one image, you would have the structural anatomy of the valve, and then AI would tell you, hey, this looks like a rheumatic valve or not. Yeah.
Okay, thank you.
My name is Magdi Abdelhamid from Cairo University. This is a great session with excellent presentations. We just published in the current issue of European Heart Journal an interesting data from the European Valvular Heart Disease Registry. I'm the first author of this presentation. We demonstrated that the implementation of the guidelines in patients with rheumatic mitral valve disease is poor, especially in patients who were previously subjected to interventions, surgery or percutaneous approach. So how to implement the guidelines early to improve the outcome of patients with rheumatic mitral valve disease? Because with time, the predictors of mortality, as we demonstrated, are commonly seen in those patients who were subjected to interventions late.
So the question is how to improve mortality.
Implementation of the guidelines in patients with rheumatic heart disease.
I think from all of the above, what you have been hearing, that we need to know the basic mechanisms, and we have had several ideas regarding mechanisms. Then you can attack one pathway after the other. It's going to be multifactorial. It's not going to be one thing. It's going to be more than one thing. And have a vaccine, look at which pathway is involved and have countermeasures, and obviously mechanical things like mitral regurgitation, this and that. You have to roll for correcting that either percutaneous or by surgery, etc., etc. Have I answered your question?
Yeah, great.
Thank you. Ismail?
Thank you, Ismail Hamamsi. This has been a very good session. I have two questions. The first one is rather simple. The second is more, just a more global approach. But the specific question is to the surgeons, Ahmed and everybody. So antibiotic prophylaxis after a ROS or after any mitral valve intervention, are you still recommending it if you're operating on a 20-year-old, or do you think it has no role on recurrence, survival, any of all of the adverse events down the line? What's the role of prophylaxis?
Thank you, Ismail. I think it sounds like a simple question, but actually it's not, because many times after not just repair procedures, but replacement procedures for rheumatic valve disease, both the patient and their doctors forget about the continuing prophylaxis afterwards. So I would recommend continuing to take prophylaxis against rheumatic heart disease, penicillin prophylaxis, whether we repair or we replace the valve afterwards.
And that's a lifelong recommendation, Ahmed, or there's an age limit that after which you say, okay, now you're past 45, it's okay, you can stop?
I think there is some debate about for how long you need to continue it for, but I think what we do in our practice is beyond the age of 40, and then afterwards you stop it. It's one of the very difficult things to adhere to from a patient point of view is having this penicillin shot every single, every fortnight or something for the rest of their lives. But I think this is a best case scenario sort of situation.
Related to your question again, there is a subset of patients who die during the acute phase of rheumatic fever or rheumatic carditis. And the question has been, they all have severe mitral regurgitation. Is this due to myocarditis or causing failure or a mechanical lesion? Interestingly, the evidence is towards a mechanical lesion. If you repair the mitral valve during the very acute stage, you save these children. So that's a very interesting thing, that myocarditis as such, although you see Aschoff nodules, the myocardium is not a big target during the acute stage. Mechanical mitral regurg is very important.
And my other question is a more general one. Winning the battle against rheumatic disease I don't think is about screening, it's about preventing it altogether, as was already mentioned. For us Egyptians, we are aware of one campaign that was very successful, at least as far as I know, which was the campaign against bilharzia back in the day, maybe 40 years ago or so, and that really reduced the rates of infection and liver failure, etc. And this is a disease of the poor as well. It's no different than rheumatic disease. Why is it that we are unable to generate a national campaign for something for which the treatment is so cheap, readily available, and it shouldn't be really that complicated? So what are the barriers? And more importantly, are there examples of other countries in Africa or countries that were low middle income that became high income countries like China or otherwise, where this has been a successful national campaign to do so?
I mean, another factor, of course, is raising the socioeconomic condition, but that will take a long time.
And I don't think this is a realistic goal. And if you look at bilharziosis, it was reduced despite not really increasing the socioeconomic.
We haven't got time.
So, but it was very aggressive national campaigns on TV and ads So what can be done? What can be learned from experiences where it actually did work?
A vaccine is another very effective way of treating smallpox.
Ishmael, maybe I can answer your question as to why we're not managing as opposed to actually giving you the solution. And that is, in low-income countries, you have many competing diseases of the poor: tuberculosis, HIV, maternal health, infant mortality. And so you're competing against all of these very grave diseases that the governments are looking at. And so it's trying to sell rheumatic heart disease and infrastructure going into rheumatic heart disease that is the problem.
And are there any success stories or that we're aware of?
Yeah, I think one of the issues is it overlaps with a lot of diseases that you see in poor income countries. If fever, cold, you go to any pharmacy or any place, it's malaria. You get treated for malaria, and then so the latency of the disease is part of the problem. And the national will and success. Rwanda is an example of a country where they made it a national priority to try to reduce rheumatic heart disease. And it was not, by decentralizing care, making sure that it's not just giving access to those who can, but making sure that it goes out into the communities. They did a remarkable job of reducing the incidence of rheumatic heart disease by using, pictures and drawing books and educating school children how to recognize this problem. But it takes a national effort. But as he said, most of these poor income countries, low income, have so many things competing for the scarce dollars that they have, and it requires usually higher income countries helping out. And as we know, the will to do that is declining, and it's going to decline even further.
Well, back to your question. In Egypt, rheumatic heart disease is not a top national problem. So I think that the main cause is because we don't have epidemiological data. We don't actually have data to show that it is a huge problem. And even when we started screening programs for chronic diseases in Egypt, we didn't include rheumatic heart disease. So we are screening for diabetes and hypertension and so forth. We didn't include rheumatic heart disease because on paper, rheumatic heart disease is not a huge problem because we don't have data.
I think I want to comment on the last question of Dr. Ismail. The main difference between bilharziosis, measles, smallpox, and other diseases that science and Egypt could eradicate is in some of those diseases are only human host. So cutting the infection from all humans at a time means that there is no place for the agent causing the disease, as that it cannot be transmitted. Bilharziosis in particular had a main advantage, and that was my question. How can we screen? Bilharziosis can be screened by urine analysis or stool analysis. They have the ovum of the parasite. So you can know which one is having the disease, and you can take 4 pills of praziquantel, 600 milligrams. We were taught this in the faculty. And no bilharziosis is there. So only human host, easy screening by simple urine test, and very effective single-dose treatment. This is not the condition with rheumatic fever, because infection is multifactorial, detection is very difficult. There is no 100% sure test, unlike bilharziosis. So you cannot cut the cycle of infection and chronicity. Thank you.
We have 2 minutes to go. So very quickly, please. Can we hear from 3 of you? Very quickly, short comments, please. Thank you.
Chris Malaise, cardiac surgeon, Northwestern. Who makes the final diagnosis of rheumatic valve disease? Is it the surgeon or is it the pathologist? And if it's me, how can I tell in the operating room that is rheumatic valve disease? Because Americans also have autoimmune disease.
It should be a combined effort in the heart center. Next, please.
I just want to make a small comment. I am from India, in central India. In my demography, what I have observed, I do rheumatic repairs. So what I observed that I get more aggressive kind of disease and predominantly mitral stenosis. And female preponderance is there and younger age of presentations are there. Whereas in other Asian countries, we can even find mitral regurgitations and caudal rupture and older population. And I do repairs, and in repair, I invariably give prophylaxis of penicillin and azithromycin. dual prophylaxis, so that I wish that my repair should last longer until these patients become candidates for a tissue valve replacement. Because these young females, for anticoagulants compliance is very difficult. I'm sure that these patients won't come back to me for follow-up. So that's what my take, why there is so demographic differences in the aggressiveness of the disease, female preponderance, more of mitral stenosis, it is because of overcrowding, or I don't know. Even in India, different states have different kind of demography of presentation regarding aggressiveness and gender distribution in rheumatic patients.
The question you have is, what do we do after mitral valve repair in rheumatic heart disease? Well, that applies to all patients with rheumatic heart disease. Whatever we are using, we should use it more in the secondary prophylaxis because they are likely to have another. Final question, please.
Thank you.
Thanks. It's more a comment. I think this session already is a success. Bruno Podesser from the Medical University of Vienna, because there have been no sessions on rheumatic heart disease on major society meetings. And we are from the Cardiac Surgery Inter-Society Alliance, together with Emily Farkas. We have unified, with Peter Siller in the back and Jack Polman, these major societies. And that makes a difference. Rheumatic heart disease will be discussed on the upcoming EACTS meeting. It will be discussed on the upcoming AETS meeting. And that is a major success of all of you. Thank you for that.
Thank you very much. Now we have to conclude. We are just, this has been a very lively session of an important topic, because a neglected disease in this day and age, which requires concerted efforts. Thank you for all the comments and the speakers and everybody. Thank you.